Hello, everybody. So let's discuss together the management of atrial fibrillation according to the latest and updated guidelines of the Royal College of Surgeons of England. What is the model answer in the exam for management of AF and for your entire life, for your career, for your teaching sessions? You must be aware of what I'm going to say now. So let's swim in the pool of science and see together how you're going to manage this condition. First of all, you must start your answer by saying, I will manage my patient according to the ABCD approach via care of critically ill surgical patient. Don't say CREST. Most candidates say CREST. No, don't say like that. Just say like I've just said. Care of critically ill surgical patient. Does that sound clear? I hope so. So this is what you're gonna say. The care of critically ill surgical patient protocol by securing patent airway and adequate breathing and circulation. We will consider the anticoagulation, only unfractionated heparin. Don't mention any other type. Don't say warfarin, don't say low molecular weight heparin. You will say unfractionated heparin because it is very rapid in action. If the condition is more than 48 hours, as mural thrombus after 48 hours is highly expected. Next. To confirm, then, you will say like that. To confirm my diagnosis, I would follow four main modalities. I would follow four main modalities. What are the four main modalities? Let's see together. Clinical, labs, imaging, and invasive procedure. The clinical will be the care of critically ill surgical patient. This is number one. The labs is going to be for CBC, coagulation profile, creatinine, and cardiac enzymes, and ABG, glucose and liver function. The imaging, the most importantly, is the ACG, then the echocardiogram. Sometimes the mural thrombus cannot be well visualized via the normal echocardiogram, so the transesophageal echo is going to be your modality. I hope it's more clear now. Next. Then you will classify the patients into two subtypes to detect the hemodynamic stability. In very simple word, what does this word mean? Unstable and stable, hemodynamically stable. Hemodynamically unstable, it means shock. It means blood pressure is hypotension leading to hypoperfusion. So you have no choice here. Because the patient is already dying. So if I left him untreated, he's gonna die. So maybe he's having thrombus, but the possibility to live longer with DC shock is higher. So we're gonna give him DC shock, whatever is the circumstances. Okay? So, and the stable patient, his blood pressure is normal. So we will subdivide into acute and chronic. Next. The chronic AF will be treated by 1 and 2. One is digitalis for stabilization, stable of the heart rhythm. Beta blockers, it is sympathogenic. It is blocking the effect of the sympathetic system, so it is depressive. It is depressing the heart rate, and this is stabilization. This is the treatment of chronic AF. The chronic AF, the patient is used to this. It is not an emergency because his life is to have AF, so it is not acute. It is not the first time. For the acute type, and this is like we surgeons, we met this many times, the worst, less than 48 hours, more than 48 hours. If the presentation is less than 48 hours, so the possibility of having thrombus is very low, so the cardioversion. If more than 48 hours, you confirm that there is a thrombus, so you will treat it with beta blocker and digitalis until the thrombus is completely cleared by the unfractionated heparin, then you will proceed to the cardioversion. Okay. But here, if there is no thrombus, proceed to cardioversion. The cardioversion, we have two types. You must answer the question like I'm teaching you now. When is the DC shock, the electric cardioversion, is absolute indication? When the patient is hemodynamically unstable, you have no choice. When the patient is asthmatic, the chemical cardioversion is depending on beta blockers. So when you give chemical cardioversion, you will kill the patient by status asthmaticus. So here the beta blockers are absolutely contraindicated. So you have only one choice, which is the DC shock. Next, the chemical cardioversion. In more details, the chemical cardioversion is like we see here. The beta blocker amiodarone here, the amiodarone. So we will say 330, 900. It's very easy mnemonic. How? This is 300, okay? And then 30 minutes here, every 30 minutes, and 33 multiplied by 3 is 9. So we will say 339, 300 milligrams IV every 30 minutes until the sinus rhythm obtained. You will give him with no stop until you have the sinus rhythm. Then the 900 will be over infusion over 24 hours. The anticoagulation. The anticoagulation, you must say just this: unfractionated heparin. I will give 70 units per kg as a bolus, one shot. Then 15 units per kg until the APTT, the activated partial thromboplastin time, is double the normal. In the exam, you can say APTT normal. We will accept that. The normal is 20 to 30 seconds, so the double is going to be 40 to 60. Next. The most importantly, that you can fail the whole station if you say low molecular weight heparin. It is a big no. It's a big mistake. It's a fatal mistake. Candidates fail this station because they say low molecular weight heparin. So this is a very fatal mistake. It can make you fail all the station. Never, never in phone call. You will find this question in the phone call station. You will find this question in the clinical station, in the knowledge. Whenever you've been asked this question about AF, never to mention no low molecular weight heparin. You will fail all the station, even if you answered all questions correctly. This is the end of this presentation. I hope you're gonna have all of you a nice shining day today. Have a nice day and thank you.